Cardiology section, and we're going to cover a fair amount of physical exam type findings with this section. And those of you who are students, and first of all, if you're graduating, congratulate. If you're graduating, congratulations. That's what I'm trying to say. And proud for you. Just get out of there and go find a job now. I know that's the hard part sometimes, but hopefully you got some leads and it'll be an easy search for you. But some of this, for those of you who are students, this is going to be familiar stuff. So a lot of the physical exam stuff you've had to learn during PA school, it's going to be pretty familiar. We have to learn the cardiac murmurs that could be on the board exam. So we're going to pick out some fine points of it and make sure you're familiar with it. And then we'll do pericarditis, myocarditis, and endocarditis, and atrial fibrillation. AFib gets its own time outside of the EKG lecture. And so this really will be the only time I cover AFib. We won't do it at the end of today in the EKG section because there's so much to talk about with AFib. So I want to make sure you get it all right here. All right, so let's talk about the cardiac exam.
Sorry, Robin, before you get started, can you go just a little closer to the computer? It's just a little bit echoey.
My
Yeah, unless everybody else thinks it's okay. On my screen, it sounded like that. I want to make sure everybody can hear. I don't know if anybody wants to type anything in the Q&A quick before he gets started.
How about now? Is that better?
Try the other one again.
I think this microphone will work better now.
Okay. Sorry. Just wanted to make sure everybody can properly hear you.
No, I appreciate it. So when it comes to doing the cardiac exam, of course, we're going to auscultate the heart, but we also want to make sure that we're palpating the precordial area, and meaning there are some patients who have a palpable heart murmur, and we call that a thrill. It can also be related to a shunt, so a ventricular septal defect, so a shunt between the ventricles, a lot of flow, high flow between those two ventricles, and that can lead to a thrill. On the next slide, we'll talk about grading murmurs and what's a 1 out of 6 and what's a 4 out of 6. So we'll go through that. A lift or a heave, you can actually see it. So you're looking at a patient from a side angle and you're able to see a lift or a heave in the parasternal area. That usually indicates ventricular hypertrophy. So that patient has a thicker ventricle than they should and is hitting up against the chest wall, producing that lift or heave on physical exam. Now, when it comes to grading heart murmur intensities, this comes with experience. In PA school, we did clinical, practices and physical exam practices on each other, so we were all pretty normal. But when you get into clinicals, and certainly me, I started off working in cardiology. And so I went straight to where people have heart murmurs and heart valve problems all the time. And if you go back and look at my initial progress notes where I did physical exam on these patients that I saw in the hospital, if they ever had a murmur, I always documented it as a 2 out of 6 systolic ejection murmur, because I just didn't know. I didn't know, but I knew the definition of a 2 out of 6 was audible to anyone who listens attentively. And that was me. I was listening as hard as I could. I heard something, but then as I got more experience, I'd hear another one. The next patient, ooh, that's a little louder. That must be a 3 out of 6. Not palpable yet. 4 out of 6, loud murmur. And now it comes with that precordial thrill, which feels like that little motor inside of a cat that you hear purring. And then a 5 out of 6, your stethoscope just above the chest wall, you hear it. A 6 out of 6, you can hear their murmur without a stethoscope. But to me, that means you put your ear down to that patient's chest, and I don't do that. That is just weird. So I really never documented a 6 out of 6. Even if they had one, I wouldn't admit it that they had it. So most everybody falls around a 2 or a 3 out of 6 when you're doing this on patients. This big old hairy guy shows you the areas where you're supposed to put your stethoscope: the aortic, the pulmonic, the tricuspid, and the mitral areas. And on the next slide, we'll lay that out anatomically for you. But along that mid-clavicular line, you should feel an apical pulse in that area. When that apical pulse gets pushed out laterally, then that indicates that patient's heart may be bigger or thicker than it should be. And if you have, the way I remembered this APTM was all physicians take money. I don't know, that was me. If you have your own mnemonic, your own way of remembering these things, you keep it. And then if you've not been in PA school for a while and you forgot this, I encourage you to spend a few minutes on this slide, because this one lays out anatomically where the valve is best heard. And they may incorporate it right into the middle of a question. They may just say the patient has a second intercostal space, right upper sternal border, and they may go on with a question talking about that murmur, but at least it narrows it down to what valve they're talking about. So sometimes if you just know the anatomy of where that valve is best heard, then you can start to narrow down what they're really trying to ask you and maybe what the answer to that question may be. So again, all these are pictured, and it's really not where the valve is. It's kind of where the sound radiates to when you're doing your auscultation on these patients. All right, let's look at how blood gets to the heart. I just want to go through this because I think it's just a good reminder. We sometimes forget right and left side valves. So let's go through this and then we'll make some points about it. First of all, blood comes back from the superior vena cava and the inferior vena cava. They both dump into the right atrium. And then blood comes from the right atrium, crosses the tricuspid valve, that's the first valve on that venous side, into the right ventricle. And then the right ventricle during systole pushes blood out of the pulmonic valve as it heads to the lungs to get oxygenated. Now stop right here for just a second. If a patient has a saddle pulmonary embolus, so a big life-threatening pulmonary embolus, this bifurcation is the saddle. So this is what they're talking about, right at the bifurcation where both main stems of the pulmonary arteries are full of clot. So that's the one where the patient shows up with an obstructive shock. Okay. Blood heads out to the lungs, gets oxygenated, returns through the pulmonary veins, and the pulmonary veins bring blood back to the left atrium. There's actually 4 entrances, not just one big one. And blood comes into the left atrium. It's pushed across the mitral valve. So that's the first valve on the oxygenated on the left side of the heart. And then during systole, blood pushes blood out of the aortic. The ventricle pushes blood out of the aortic valve and where it gets disseminated to the body. So look with me for just a second. I want you to put this in your brain real quick because I'm going to use it and talk about it over the next few minutes. These 2 valves that sit close together, the pulmonic and the aortic valve, the PA valves, they open and close at the same time. All right. So in a minute, when we talk about lub and dub, we're going to talk about the pulmonary and the aortic valves open and close at the same time. And then the tricuspid and the mitral valve, TM valves, they open and close at the same time. All right. So we'll deal with this. We'll talk about the lub, the dub, which is S1 and S2. We're going to talk about the S2 split. We're going to define the gallops and what that's all about because I don't think I knew what that was until after PA school. And then we'll do murmurs. So hopefully we'll kind of, again, work through some heart sounds and then we'll work on those murmurs in just a minute. So let's start real easy. S1 is a sound made when the mitral and the tricuspid valves close. It marks the beginning of systole. All right, we said a while ago that the mitral and the tricuspid valves, they open and close at the same time. So the closure of those 2 valves that sit between your ventricle and your atria, they need to be slammed shut during systole. What is systole? Systole is when both ventricles pump blood out of the heart. So it just makes sense to me that the mitral and the tricuspid valves need to be closed during systole when blood is getting pumped out of the heart. Okay. So S1 is loudest at the apex, and that's the bottom of the heart. That's where you'll hear S1 more predominantly. And so that is what S1, the lub dub, is all about. The mitral and the tricuspid valves, those 2 kind of inside valves between the atrium and the ventricle that close. Then S2 is related to the PA valves. The pulmonic and the aortic valves close at the same time. That's what produces the dub of lub dub. And it says it marks the beginning of diastole. Well, what is diastole? Diastole is when blood comes from the atrium down into the ventricles. So it kind of makes sense that the tricuspid and mitral valves, they're going to be wide open to allow blood to come down. But the aortic and the pulmonic valves need to be slammed shut to prevent blood from getting out of the heart. So the S2 heart sound, the dub of lub dub, is when the PA valves close. S2 happens to be loudest at the base, and then we have to talk about an S2 split. If we're really good at listening to each other's hearts, we should be able to recognize that when I take a deep breath in, if you were listening to my heart, my pulmonic valve closes slightly later than my aortic valve. And that's related to you take a breath in, you increase blood flow into the lungs, and that's what ends up producing a little bit of pressure to cause that split S2. Now, there are some patients that have a fixed split S2. And look at my picture down here. So the picture shows shunning of blood from the left atrium across this atrial septal hole defect down into the right ventricle, which puts a little bit of pressure on that pulmonic valve so that it closes slightly later than the aortic valve every single time the patient's heart beats. During inspiration, during expiration, with every beat of their heart, with every breath that they take in or out, there is a fixed split S2. That is consistent with an atrial septal defect. Okay, so we kind of all do it in the first place. If you can hear it, but you're a patient with an ASD, it happens all the time. Now let's work on the gallops. So an S3 gallop and an S4 gallop, they're both related to blood coming into the ventricle and hitting the ventricular wall. It's just a matter of the timing of when it happens to help you get to kind of a diagnosis of why it's happening. So look down here at my diagram. I've got S1 and S2. S3 is right after that. And S4 is right before S1. We're going to deal with that in just a few minutes. Everything between the end of S2 and the beginning of S1 is the diastolic filling time. All right. So everything between the end of S2 and the beginning of S1 is diastole. So let's go back to our bullets up here. S3 is heard early in diastole just after S2. All right. I've got that picture in my brain to help me remember that. Then it says an S3 sound is made by rapid ventricular filling, or blood hitting that ventricular wall right after the mitral valve opens. Both gallops are related to blood hitting the ventricular wall. All right, so that's not a big point at all. What is a big point is who has an S3 on exam. Young athletes, so with healthy hearts, can have an S3, and it's completely okay. That's just fine. There's no problem with that. But where I want you to really remember is patients with congestive heart failure, left ventricular dysfunction, maybe their ejection fraction's 25%, 35%, not very good. They have extra volume coming down and hitting that ventricular wall. So it is related to extra volume hitting that kind of non-compliant ventricular wall. That's what's going on there. So in PA school, they taught us about Kentucky and Tennessee, but man, I could never remember which state went with which gallop. And so later on in life, I learned sloshing in, sloshing in, sloshing in, where sloshing is S1, S2, and the N is the S3 gallop. All right. So that helps me remember the timing of it. But then it also helps me remember this patient's got extra volume. They got extra volume hitting that ventricular wall, just like in congestive heart failure. So an S3 gallop goes along with heart failure, and some athletes can have it. S4 gallop occurs right before S1, and it is never normal. People shouldn't have an S4 gallop. It's bad. But it's atrial contraction of blood into a stiff ventricle. So now blood's coming in right before the love of loved up, hitting that ventricular wall, and it is a stiff ventricle, usually related to ventricular hypertrophy, which is a result of uncontrolled high blood pressure for a long time. And then also you think about this in patients after a myocardial infarction. Their wall just is not as compliant. It doesn't move as well as it should if it's not revascularized, especially. And so patients with ventricular hypertrophy and a myocardial infarction can have an S4 gallop on exam. Tennessee is the state. You can remember that. You keep that. But I like a stiff wall, a stiff wall, a stiff wall, where the is the S4 gallop, S1, S2 is stiff wall, and it helps me remember who has, just helps me remember who has an S4 gallop. It's patients with this stiff ventricular wall, and that's the way I remember those gallops. Now let's think about functional murmurs. There are some folks who walk around, or maybe there's something wrong with them right now, and they have a functional murmur. And it's always related to high cardiac output. So there's increased flow across the valve, not necessarily a valve problem. There's no pathology. Examples, during pregnancy, you have high cardiac output. If you're anemic, you have high cardiac output. Young athletes and their athletic parts have high cardiac output. So those are reasons that a patient may have just this physiologic ejection murmur. And then we'll also hear some what's called innocent murmurs in pediatrics, where they have this little soft systolic murmur, and it's related to their heart has not quite taken on the shape that it's supposed to. And as it does, then it kind of straightens out that valve, and they have better flow across that valve once they get up into a few more years in their childhood. So you'll see that innocent murmurs in pediatrics, functional murmurs in adults due to high cardiac output. All right. This kind of drives that part home about the systolic period, the diastolic period, but it also relates to murmurs, when you're going to hear the murmurs. So systolic murmurs are heard between S1 and S2. And in my brain, I kind of think of the S1 as more systolic sound. So some blowing sound, some harsh sound during S1. But a diastolic murmur is going to happen right after S2. And to me, a diastolic murmur occurs with the dub of love dub. So diastolic and dub, that's how I remember that. If you're not sure of a murmur's timing, and this won't help you on the test, but it will help you in clinicals, during auscultation, if you're listening to the patient's heart, you can, if you hear the murmur at the same time you feel their pulse, so palpate their pulse somewhere at the same time. If you hear the murmur at the same time you feel the pulse, that is a systolic murmur. Okay. So if you auscultate the murmur at the same time you palpate the pulse, that is a systolic murmur. And it helps you kind of figure out which one is diastolic and which one is systolic. We're going to have 4 systolic murmurs to worry about and 2 diastolic murmurs to worry about. When it comes to the blueprint, as far as what's going to be on the board exam, the website kind of tells you what's supposed to be on your board exam, and it says valvular heart disease. And it used to say these specific valves, and actually it might still, but I'm pretty sure it just says valvular heart disease. Well, I've picked out kind of the 4 systolic murmurs that you have to know about, and the 2 most common diastolic murmurs. And we're going to go through each one, and I'm going to give you kind of what the picture looks like, what the patient presents with, the etiology of what can cause this valve problem. But just remember, with all of these, it's abnormal flow across the valve, and either the valve is leaking, and that's regurgitation, or it's stenotic. And let me say this while I'm thinking about it. If you ever see a term on your board exam or in real life, and it says, instead of mitral regurgitation, it says mitral insufficiency, that's the same thing as regurgitation. So insufficiency and regurgitation are synonymous when it comes to valve problems. A calcified or stenotic valve is usually related to a valve that's not opening as well as it should. And so blood flow is forced across that valve, and that's what produces that murmur. Down here, the way I've remembered this is just my brain, but the 2 diastolic murmurs are aortic regurgitation and mitral stenosis, which the first letters of that spells ARMS, which has absolutely nothing to do with the heart, but I have that in my brain now, and everything else is a systolic murmur, basically, for what we need to do for the board exam. Here's some other ways to remember it, and if you want this, you can have them, that's fine. And you may have your own. If you have your own, you just keep it, and you got it in your brain, you keep it there, okay? All right, let's start with the 4 systolic murmurs, and we're going to start with mitral regurgitation. It is very common to see patients with mitral regurgitation. So this is the first systolic murmur. So during systole, what is supposed to happen is this left ventricle is supposed to pump blood out of the aortic valve, and that mitral valve is supposed to slam shut. But unfortunately, those valves don't close together, and so blood regurgitates back across that mitral valve, and that regurgitation of blood produces the murmur with mitral regurgitation. And the way they describe it is being holosystolic. That makes sense. All between S1 and S2, it's all during that time that you'll hear this sound. And they describe it as a blowing with constant intensity and best heard at the apex. And that's mitral valve is in that fifth intercostal space, so that makes sense to me too. So mitral regurgitation, polysystolic. There might be an S3 associated with this because a lot of times there's some volume overload and heart failure type symptoms with mitral regurgitation. Let's think about the etiology of mitral regurgitation. You can have, we're going to discuss it by itself in a minute, mitral valve prolapse, where the valve prolapses up into the left atrium so it doesn't close well, and that can lead to mitral regurgitation. You can have ventricular dysfunction where the ventricle gets bigger and bigger and bigger, and so it stretches out that area around that mitral valve and leads to mitral regurgitation. Ischemic heart disease, so coronary disease that affects the mitral valve, the muscle that helps that apparatus work in the first place. And then it can happen acutely. So generally the way that happens is a patient has a myocardial infarction. A lot of times they go home in 2 or 3 days, and then they come back 3, 4, 5 days later with acute heart failure symptoms. We do an echocardiogram. They've got a brand new murmur. And what's happened is that infarct that they initially had did some damage to the papillary muscle or the chordae that hold on to the valve leaflets, and now they let loose. So the mitral valve is kind of flopping in the wind and not working at all. So these patients will have blood backing up to the left atrium. That puts pressure back on the lungs. So for the most part, the real main symptoms of mitral regurgitation are dyspnea, orthopnea, so left heart failure type symptoms. Treatment for all of these things, blood pressure control, valve repair, or replacement. I wouldn't even worry about treatment for any of these valve problems. That's just me, because it's the same thing. Control the blood pressure and fix it if they need it. So I wouldn't worry too much about the treatment plan for these patients. The next systolic murmur is aortic valve stenosis. Aortic valve stenosis is a calcified aortic valve. You see in the picture there. So the left ventricle is doing everything it possibly can to pump blood across that calcified aortic valve. So it's getting the work out. It gets bigger and thicker and thicker and thicker. And there's limited flow across that aortic valve. So the murmur that's associated with this, it's systolic, crescendo, decrescendo, and really harsh sound, second intercostal space. It almost sounds like somebody clearing their throat. It is pretty obvious when you put your stethoscope up there how harsh it is. And then this is the only one that radiates to the carotids and the neck. So you'll hear when you put your stethoscope up to the carotids, it sounds like they have a carotid bruit, but in fact it's originating in the aortic stenosis valve area. Crescendo, decrescendo is just loud and tapers off. Kind of all the valves have that either, it may be decrescendo, crescendo, so it might be the opposite. Again, I wouldn't worry too much about that, but for aortic stenosis, I see it described that way in the review books all the time. And we don't use that terminology in real life, but it's definitely a harsh quality radius to the carotids. Who has it? You can be born with it. You can be born with congenital aortic stenosis. You can be born with a bicuspid aortic valve. It should have 3 leaflets. But when there's only 2, then in your 40s and 50s, you begin developing aortic valve stenosis. And you might need that fixed in your 50s and 60s. Calcific aortic stenosis is what older people get. The longer you live, the more likely you are to have it. And it comes from even high cholesterol can cause aortic stenosis. So I told you earlier, I found that I've got high cholesterol, so now I've got to worry about aortic stenosis in my future one day too. So the best we can do is watch for these patient symptoms. So exertional fatigue, shortness of breath, syncope with exertion. So that's one thing that's going to show up as it gets to that severe and critical state of aortic stenosis, and then also angina. Okay, so angina shows up for chest pain and syncope with exertion. That's what you'll find in patients with aortic stenosis. Fix it. Down here's a picture of getting your valve fixed with a transcatheter aortic valve replacement. We get femoral access, Catheter goes up. We deploy this brand new device, squishing the old aortic valves, leaflets up against the aortic wall. And then once they take that balloon out, there are new leaflets inside that balloon that now function as your aortic valve. And this is done in the cath lab under anesthesia. The patients go home the next day. And so this helps avoid open heart surgery, which has traditionally been the only way to fix those valves. Tricuspid valve regurgitation. Now you have this leaky valve during systole. The only thing that's supposed to happen is blood gets pumped out of the pulmonic valve. But unfortunately, your tricuspid valve does not close well. So when the right ventricle squeezes, it squeezes blood across the tricuspid valve. And that produces the murmur that they term as high-pitched pansystolics. So all between S1 and S2. And I don't know what the difference between holosystolic with mitral regurgitation and pansystolic with tricuspid regurgitation. I don't know. I don't know the difference. But the giveaway for tricuspid regurgitation is it's accentuated with inspiration. So the murmur gets louder when that patient takes a deep breath in, listening to that typical place of left lower sternal border, okay, fourth intercostal space. That's where you'll hear it. The TR gets louder with inspiration. Who has it? Patients with pulmonary hypertension. They get very high pressures in their lungs, and that puts pressure back on that valve where it doesn't close well. Dilated right ventricles. When patients have pulmonary hypertension, their right ventricles get bigger and bigger, and it stretches that area around that tricuspid valve so that it does not close well. Epstein's anomaly is a congenital malformation, and it made it to the review books just enough for me to leave it on my slides. And usually some other cardiac malformations are present with Epstein's anomaly. And then, of course, endocarditis. That's the first valve that bacteria might hit as it moves through the heart. And so you can get endocarditis of that tricuspid valve. Thinking about the signs and symptoms, if blood's backing up through the tricuspid valve, then it's going to put pressure back on the venous system. So jugular venous distension, ascites in the belly, peripheral edema, these are things that you'll see related to tricuspid regurgitation. And again, a lot of times goes along with pulmonary hypertension. That's where we'll see this. Finally, pulmonic valve stenosis is your last systolic murmur here. So what's happening during systole is blood is supposed to get pushed out of the pulmonic valve and supposed to be wide open, but unfortunately it does not open very well. And so blood is forced across that pulmonic valve, and that's what produces the murmur. And this is truly the only time we see this, or only time I see it, is in congenital cardiac malformations. We just don't see this much in adults. And it can be severe. These patients can be born cyanotic at birth, and more fatigue, more dyspnea into their toddler days if they don't get diagnosed at birth, and it gets worse over the next year or two, then they'll get short of breath and fatigue. So second left intercostal space, that's where you typically hear pulmonic valve problems anyway. And that's generally where you'll hear this systolic murmur. So again, still between S1 and S2, but in that pulmonic position. All right, those are the 4 systolic murmurs. Let's talk about the 2 diastolic murmurs. Now you've got a patient with, during diastole, what's supposed to happen? The ventricle fills with blood coming from the left atrium down to the left ventricle, and that aortic valve is supposed to slam shut, but it doesn't. Blood leaks back through it, and that leakage of blood back across that aortic valve is what produces the murmur that we see with aortic valve regurgitation, this diastolic murmur. So now your blowing sound, this decrescendo diastolic murmur is going to happen right after S2, kind of in the dub area of love dub, okay? So this one's a little bit tricky as far as where you listen to it, and it's just maybe hard to remember, but it says loudest at the left sternal border, which in the third intercostal space, which might be called Erb's point, with the patient leaning forward and holding their breath. So there's a lot of stipulations to be able to hear aortic regurgitation. First of all, it's not where it's supposed to be. So it's on the left sternal border, third intercostal space. Have the patient lean forward, hold their breath, and you might be able to hear that diastolic murmur with aortic regurgitation. I think one of the things we see is patients with high blood pressure. It stretches that area, that aortic root area, which is the ascending aorta, and that's what causes that valve to be floppy, and it just doesn't work as well as it should. Marfans have aortic problems and aortic valve problems early in life. So make sure you're keeping an eye on them from their 20s to 40 years old, is where sometimes their valves and the aortas begin to have trouble. So blood's backing up, and so some of the hemodynamic things that you see and some of the words and descriptors that they have for aortic regurgitation is a widened pulse pressure, meaning their blood pressure will be 160 over 40. And I know that's ridiculous, but you kind of get my point. There's a lot of space between systolic and diastolic numbers. That's what a widened pulse pressure is. Corrigan pulse is a water hammer pulse. I had a patient one time, he liked to shoot up drugs in his IV, in his vein. So he was putting the tourniquet on his upper arm, and he could feel his own water hammer pulse. And he had developed aortic valve endocarditis, and it was affecting his valve function, making him have aortic regurgitation. So again, one of those peripheral pulse changes associated with aortic valve regurgitation. Another one is Trobe sign, where you can auscultate these loud, sharp, quick femoral pulses as you put your stethoscope over that femoral artery. Those are all hemodynamic, and I don't know if I can explain them all, to be honest with you, or what's going on and why that's happening, but it has a lot to do with the backwards flow of blood back into the left ventricle when it's doing it. So if blood's backing up, these patients may have pulmonary edema. Some of them have angina. They need an aortic valve replacement if it gets severe. And then finally, the second part of ARMS, mitral valve stenosis, really thick, fibrotic mitral valve. And you see the trouble that blood's going to have getting across that mitral valve because it's so thick and obstructive. And blood just kind of has to rumble across it. And that's the way they describe mitral stenosis. It's a low-pitched diastolic rumble. So now over around S2 or right afterwards where you'll hear this murmur. And then oftentimes there's an opening snap also right after S2, caused by the delay of that thick stenotic valve to open. It just pops open, and that's what produces that opening snap. I don't think you need to remember too much more with mitral stenosis besides rheumatic heart disease, that history of a group A strep infection. That's what causes mitral stenosis almost every time. Okay, so if a patient has mitral stenosis, it is most likely due to a history of a group A strep infection and rheumatic heart disease. It is interesting that AFib is common with this. And so if you're thinking back to that picture, that left atrium is bigger than it should be. And people with big atria have atrial fibrillation. So it's common to see atrial fibrillation associated with mitral stenosis. All right, that's the 6 valve problems you probably ought to know for the board exam. Be familiar with them. I've mentioned doing valve repairs, valve replacements, so let's talk about them here. Just real quick. So when a patient has valve repair, they leave the existing leaflets and they tie this ring around the valve and essentially just cinch it up, basically just pull it tighter together. And now the valve leaflets open and close, or especially close well like they should. A tissue valve replacement is taking out the old valve, putting a new tissue, bovine or porcine valve in there. And now that patient has new tissue and hopefully a valve that'll last them for many, many years. The great thing about these replacement and repair is neither one of these require long-term anticoagulation. So for both of them, you're going to put them on warfarin for about 2 months, but then they come off of it. If a patient gets a mechanical valve, they have to be on warfarin forever. So this is committing your patient to anticoagulation for life. Right now, the only kind of PO form of medication is the vitamin K antagonist warfarin. Mechanical valves will last a lifetime, and they're supposed to last forever as long as they're taken care of. They can last a real long time. But I told you earlier, anything metallic or mechanical in the vasculature that promotes thrombus. And so that's why the patient has to be on anticoagulation. Now, if they come off warfarin, we got to bridge them with some enoxaparin or heparin, we can do that. But right now, warfarin is the only one that is good for the patient with a mechanical valve. All right, let's talk about hypertrophic obstructive cardiomyopathy. And I include it here because there is a murmur, there's an abnormal heart sound that goes along with it that I think you need to know about because they love to put it on the test. And it really is important. I think it's super important. This hokum is that terrible, terrible story that you hear about the basketball player in high school or the football player, just sudden collapse, sudden cardiac death, really had no symptoms prior to this. And all of a sudden they go into cardiac arrest during practice or on the field. So when you're seeing these patients, you may be faced with the opportunity to do a sports physical, and you have to decide and figure out, do they have a murmur that's associated with a young, healthy heart, so a functional murmur, or is it in fact related to hokum? Here's the problem. So this heart on the left is normal, so that looks good. The heart on the right shows this really, really thick septum, so a hypertrophic septum. And the issue is when that heart gets to beating hard and that patient's playing basketball or football and it gets faster and faster, those ventricular walls, they get closer to each other and closer to each other to the point where they can get so close that they touch. And especially what they do is obstruct blood flow out of the aortic valve. So the obstructive part is I can't get blood out of the aortic valve because the valve or the ventricular walls get so close together, and that being close together is what produces the murmur we're about to talk about. So with hokum, let me talk to you about how you decide if the patient has, we said it earlier, they can have a functional murmur. Some people have aortic valve stenosis that sounds like this. It could be hokum. So let's talk about this. So the patient with hokum will have, the way I do their exam is, if I'm listening to a young person doing a sports physical, they may have a murmur at baseline. But the way I listen to them is I will get to the ground with them and I'll ask them to squat all the way down. And I'll listen to their heart and I'll get a good handle on what it sounds like with them in a squatting position. And then I will get that patient to stand up. And as they stand up, I continue listening to their heart. If that murmur intensifies with standing, that is concerning for a hokum murmur. All right. So if the murmur intensifies with standing, and I've got it underlined here with Valsalva maneuvers and or with standing, then that is concerning for hokum. So let's talk about why. When you squat, you increase preload back up to your heart. So that fills your ventricles, so the walls of your ventricle can't get as close together to make the obstruction occur. And then when you stand up, blood pools to your belly, pools to your legs. Preload is decreased when you stand up and when you do Valsalva maneuvers. And so that allows the walls to get a little bit closer together to increase that obstruction and give you the murmur that's louder with standing. Okay. Now, I don't care how you learn it, but I think you need to know it so you can learn it with the squatting and the hand grip, how hokum gets softer. Valsalva and standing, it gets louder. But I do think you need to know this. And typically, kids are going to come in with this kind of soft, 1 or 2 out of 6 murmur at baseline. They're going to have a murmur. And so you need to figure out, is it a functional murmur? Is it hokum? And then that helps you move on from there. All right, let's talk about mitral valve prolapse. You get this valve that prolapses up into the left atrium. And as it does, it looks like a McDonald's sign. And it is pulling these chordates as tight as they can be as it balloons up into the left atrium. With mitral valve prolapse, it usually is the women who have the symptoms associated with it. It turns out there's an equal number of men who have some mitral valve prolapse. But the women have the symptoms, and the symptoms kind of all over the place. It could be palpitations, it could be near syncope, it could be panic attacks, abnormal autonomic tone. They there's a whole mitral valve prolapse syndrome that some people can present with. On an exam, you need to know that mitral valve prolapse will cause a mid to late systolic click. There may not be a murmur associated with it, but there may be. It could, with or without a murmur. So what's causing the click is that sudden tensing or pulling of those chordae as the valves balloon up into the left atrium. It's like pulling a rope tight, pull it tight over and over and over. That's what produces that mid to late systolic click associated with mitral valve prolapse. The next bullet talks about the murmurs accentuated with standing and Valsalva. You're like, oh my gosh, that's what you just said was hokum. Well, good. Now we've got two things. Do the same thing. Hokum and mitral valve prolapse get louder with standing and Valsalva moves. So then you just have to do an echocardiogram. So their next stop is going to be an echocardiogram to look and see, all right, do we have a patient with hokum or is it mitral valve prolapse? But what do you do about it if you find a patient with mitral valve prolapse? If they have palpitations, and some people do, that when that valve gets up into the left atrium, they may have PACs, kind of bounces off that atrial wall. So you can put them on a beta blocker, see if that helps them out. Get them to exercise, stay away from caffeine, stay hydrated, all the usual healthy stuff. And then if it gets bad enough, you can fix that valve and get it repaired or replaced. Okay. All right. Let's do a question for you regarding valve problems. 77-year-old woman presents with syncope during her routine daily exercise. And her history includes several other episodes of syncope over the last 6 months. She has a systolic murmur best heard at the right external border of the radiation to the neck. Which of the following is the most probable diagnosis? It gives it away when it says radiation to the neck, right? But even if it didn't, syncope with exercise makes me think about aortic stenosis. That's the main one that does that. 59-year-old female with a history of coronary artery disease and a prior inferior wall myocardial infarction presents with 2 months of worsening shortness of breath with minimal exertion and lower extremity swelling. Her physical exam reveals a 4 out of 6 holosystolic murmur at the fifth intercostal space radiating to her axilla. Which of the following is likely the cause of her symptoms? So systolic murmur at the fifth intercostal space, that makes me think about a mitral valve. It's pretty significant, a 4 out of 6. Mitral valve regurgitation. Mitral stenosis is a diastolic murmur. In this history of coronary disease, that usually goes along with mitral regurgitation. Some heart failure type symptoms with it. 35-year-old female with a history of anxiety and panic attacks presents for a routine physical exam. She intermittently experiences palpitations, but in general feels well. Physical exam reveals a mid-systolic click, and you can stop right there because you know that this patient probably has mitral valve prolapse. She's young, she's got a mid-systolic click, she's having palpitations. That is a perfect story for mitral valve prolapse and not much else. All right, let's move on to heart inflammatory problems here. Talk about the itises of the heart. First one we're going to talk about is pericarditis, where you have an inflammation of that pericardial lining. And the books say if you don't know why a patient has pericarditis, they probably recently had some viral illness to make them have pericarditis. Echovirus, Coxsackie virus, tuberculosis infection can also lead to it, so even that can do it. And then cancer, lupus, rheumatoid, uremic pericarditis, all of these can also lead to an inflammation of the pericardium, and most of those are usually associated with pericardial effusion. Even those medications down there, like minoxidil, it can lead to pericardial effusion. And that can be the med that actually causes your pericarditis infusion. Let's talk about Dressler syndrome. I kind of made a slide all by itself because it's a diagnosis unto itself where the patient, maybe they have bypass surgery or they've had a heart attack and they go home and they come back with chest pain a few days later and they're worried about it because they just had a heart attack. Now they're having chest pain again. But what's going to be different about it this time is now it's kind of a pleuritic chest pain. You do a physical exam, you hear a friction rub. This post-myocardial infarction syndrome is Dressler syndrome. And you're going to put that patient on NSAID or a higher dose aspirin, what they're probably already on, to try to help this patient out. Okay. So that's Dressler's. I really just want you to know the name of it and who has it. Now let's talk about general pericarditis. Excuse me. So this patient, maybe they had a recent viral illness, and now it's left them with a little bit of intermittent low-grade fevers. They have this sharp pain. It tends to get worse with deep inspiration. It's worse when they're lying down, and that pain radiates up to their neck. There is some shortness of breath, and the dead giveaway is a friction rub. So if your patient has a friction rub, I don't want you to think too much more than pericarditis. It's a scratching sound, and they say it sounds like boots stepping in stuff. Kind of highly specific for patient with pericarditis. Let's talk about the EKG findings that you see with pericarditis. PR depression, that's in box A here. You'll see PR depression, that's pretty obvious. Box B shows J-point notching. So at the end of the QRS is often called a J-point. That little notch at the end of that is not normal. That should not be there. And then across the whole EKG, you'll see these concave ST segments that make you think about a smiley face. Here's a whole EKG. So almost first thing I noticed about the EKG, in almost every lead, there's some ST elevation. So you think, is it a heart attack? What's going on here? Then I start to see these concave ST segments, and it's in every lead. STEMIs won't go in every lead, but pericarditis does because the pericardium surrounds the heart. So that's why it shows up in every lead with these concave ST segments. One other way of recognizing it is these T-wave inversions in AVR. So that makes it kind of obvious too. And then look right here in lead 2. Here's PR depression. There's J-point notching. Of course, it's got the concave ST segment. So you won't necessarily see J-point notching in every lead. You may not see PR depression in every lead, but the concave ST segment you will see. Now, what do you do about it? So the treatment for pericarditis is NSAIDs for 2 weeks. So ibuprofen, indocin, naproxen, those all work. Colchicine can be started or should be started about the same time. And you'll take the colchicine for 3 months. And so that's once a day for 3 months. So the NSAIDs, colchicine, and then it says they encourage you to try to avoid NSAIDs. Try to avoid steroids because there's an increased risk for recurrent pericarditis. Now, there's some patients who have bad kidneys and renal insufficiency. And so you may be thinking to yourself, I can't give that NSAID or the colchicine to patients with bad kidneys. Well, then you've got to use steroids. So you do what you have to do. And it's going to make them feel better. They will feel better with steroids, but there's increased risk for it to happen again. It doesn't cure it like the pericarditis treatment of NSAIDs and colchicine can. All right, let's talk about pericardial effusions. So there should not be any fluid between your pericardium and your myocardium. But when there is a development of fluid in there, it puts pressure back on your heart. So your heart has trouble relaxing, filling with blood during diastole because of that big pericardial effusion. And of course, we call that tamponade when it has that effect where it's pushing against the ventricle so much that we decrease cardiac output. leads to hypotension. If there's different ways to get a pericardial effusion. It can be trauma. You get stabbed in the heart, develop fluid in there. We sometimes do it in the cath lab. Sometimes the doctor pokes a hole in the ventricle or pokes a hole in the coronary, and all of a sudden you get this rapid development of a bloody effusion and the tamponade that occurs. Your pericardium does not stretch very easily. It will not stretch, and so it takes about 150 milliliters of fluid into that area, and all of a sudden you're in tamponade. Now, the other way to get it is if it gradually happens. So inflammation leads to fluid accumulation in that pericardial space. Well, if it happens over 2 or 3 months, then your pericardium has time to stretch and stretch and stretch and stretch. And I've seen up to almost 1 liter of fluid in that space. Of course, they come in with tamponade. And you've got to do something about it because they have decreased cardiac output, compromised ventricular filling, all these things up here, along with the low blood pressure. We'll talk more about in just a second. Here's a picture of a big pericardial effusion. Black on ultrasound is fluid or blood. So here is the big effusion all the way around the heart. It's kind of cut off up here. If the test question ever asks you what's the first chamber to show evidence of collapse with tamponade, is the right ventricle. So the right ventricle is down there just sitting in that fluid, and it receives the first kind of pressure where it can't get into diastole. And so there's some collapse of the right ventricle, and eventually all of the chambers will show collapse with a bad tamponade. Beck's triad, you got low blood pressure, distended neck veins, so blood's backing up into the venous system. Muffled heart tones, there's just so much fluid between your stethoscope and the heart valves. You can't hear the lub-dub very well because of all that fluid. And then narrow pulse pressure and tachycardia. So then you have Kussmaul sign, which I always forget what that is, but it's a rise in jugular venous pressure on inspiration. So the patient takes a deep breath in, jugular venous pressures go up. And it's really all about, I can't get blood into the heart. So pressure starts mounting back up on the venous system. Pulsus paradoxus, that's a phenomenon that occurs. And you'll see that you get their blood pressure, you take their blood pressure, and then you ask them to hold their breath while you take their blood pressure again. And you'll see greater than a 10 millimeter drop in blood pressure with inspiration. That is pulsus paradoxus. And that just means you have a hemodynamically significant pericardial effusion and definite tamponade. And let me show you an EKG with electrical alternations. So when I look at this EKG, the first thing I notice is everything is smaller amplitude. All right, so everything is smaller. And then the other thing I start seeing is, look here in V2, these different sized QRSs, bigger, small, biggest, small, biggest. So these different size, what's happening here is your heart's just kind of swimming and swinging in that fluid. And as it gets a little closer to the chest wall, well, the amplitude is increased. As it swims away from the chest wall because of the way it's beating, then the amplitude is smaller. So that is a electrical alternance, and it's all related to that fluid between your 12 lead EKG leads and the patient's heart. So that's what's causing electrical. So what do you do about it? Well, if they have all this fluid surrounding their heart, putting pressure on it, then we need to do something to fill their ventricular tank. We need to give them volume initially to help treat hypotension. That's kind of easy. Then you got to set up for pericardiocentesis. So take an ultrasound, stick a needle in, draw that fluid off to relieve this patient's tamponade. That's for the hypotensive, really unstable patient. If we have a little bit of time, maybe they have a big pericardial effusion, but it's early tamponade or they're not unstable yet, we may have time to send them to surgery to do a partial pericardiectomy, where we cut a small hole in the pericardium to relieve that fluid, stick a drain in for a couple of days, let it all get out of there. And then always, always, always send that fluid off for pathology. Man, if they've had a history of lung cancer or breast cancer or lymphoma, there's concern for metastasis with pericardial effusions. So you need to really get that pathology report, make sure that they've not developed metastasis to that heart pericardial area. All right, shift gears, talk about myocarditis. It's almost always related to a viral infection. I mean, that's just the way the books will tell you. There's some other things that can cause it, and I put the other things on there, like an allergic reaction, eosinophilic, hypersensitivity, vaccine related. So again, a reaction to a vaccine. Autoimmune disease can cause myocarditis. Up in the picture up there gives a good picture of what's going on. So this thick and swollen myocardium. So it's really inflamed, thick and swollen. That is the issue. And it leaves your heart weak, so it can't work as well as it should. Patients will come in with almost flu-like symptoms, a little bit of fever, maybe a recent upper respiratory infection. And it's younger folks who have this, so ages 20 to 50 who will have it. They might present with heart failure and a dilated cardiomyopathy. If it goes on, that's the thing, if it goes on unchecked, untreated for, says 1 to 3 months, they may develop an ejection fraction that's now 20%, 30%. So heart failure, heart gets dilated and big with myocarditis. To help you get a diagnosis, check things that are markers of inflammation. So erythrocyte sedimentation rate or a C-reactive protein, those are both markers of inflammation. Your patient's troponin will definitely be very elevated with acute myocarditis. It's going to be pretty significant. And that's one of the clues that something's going on. They'll probably come in with heart failure type symptoms and chest pain, and their troponin is going to be kind of markedly increased for presentation. EKG is going to be very similar to what we saw with pericarditis, kind of concave ST segments. But these patients with myocarditis are at risk for arrhythmias. So VTAC, VFib, heart blocks that can be symptomatic. So you really ought to leave them on tele for a couple of days to make sure that you're heading in the right direction after you diagnose somebody with myocarditis. The workup to help you see if there's ventricular dysfunction is to get an echocardiogram. The MRI will show the thick and swollen ventricle, but it takes a biopsy to actually determine the etiology. So is it viral? Is it eosinophilic? Is it hypersensitivity? So, and a lot of times that gets done. You know, if we just don't know why they have myocarditis, they may get an endomyocardiopathy. So heart failure standard therapy is what we do for patients with the low ejection fraction. And in cardiology section 3 this afternoon, we'll get into that standard therapy. Worry about their arrhythmias for a few days, and then avoid NSAIDs. So NSAIDs make your heart worse. So they can cause your myocarditis, your weak heart, to get weaker. So they are not what you use for patients with a thick and swollen heart. And they need to stay away from exercise or sports for 3 to 6 months. You need your heart to rest for that long. So we do not need to put any stress on your heart for at least 3 months. And that is part of the treatment guideline, okay? Let's talk about endocarditis. So these patients come in with a valve infection. Maybe a little bit older, so now we're older than 50 at this point. And look at my picture. So the bacteria gets seated on the valve itself, and it causes dysfunction of the valve. And so there's certain people who are prone to get infective endocarditis. Again, most people are older than 50. If you've had it before, you're likely to get it again. If you have a prosthetic valve in place, you have an increased risk. You know, IV drug users would increase risk of it. If you have a previously placed pacemaker or defibrillator, then there's risk for not only the valve getting infected, but also the lead itself getting infected. And then after dental or surgical procedures, these patients are at risk. Some patients are at risk for that. Fever is the most common symptom with infective endocarditis. A lot of times people will just come in with fever and they don't have any other symptoms, and that's it. Maybe some fatigue, flu-like symptoms, but that's actually the patient where, man, if you don't know where this has come from, your fever's gone on for a week now, let's see if we can do some blood cultures. Do you have a heart murmur on exam? So a lot of times that's very common for the patient who comes in with fever. We check for a murmur, and they do have one. Hematuria related to glomerulonephritis is pretty common. And then they kind of, teach us a lot about these Osler nodes and Janeway lesions and rod spots in PA school, but it turns out they're pretty uncommon. They're uncommon but highly suggestive. And so they're very specific to endocarditis diagnosis. And I think you should know them. But in real life, what we often see is patients come in with fever, positive blood cultures, and then we do an echo or TEE to find out they have endocarditis. Okay, so if, again, the medical doctors, the infectious disease doctors started the workup, they can't find the source. Urine looks okay, no pneumonia, but you got blood cultures showing evidence of infection. It's every now and then you have a patient with negative blood cultures, and they do have some of these things going on down here. And so that could happen. I don't think you can remember majors and minors. I think that's too much. I don't think you need to remember that kind of stuff. Which one's major and which one's minor. And just think about the typical presentation. Patient comes with a fever. I can't find a good source. Now there's positive blood cultures. You better do a TEE to find out if they have endocarditis. The most common problem or source of it is Staph aureus. So that's the most common culprit. Streptococcus viridans certainly can fall in there, especially after dental procedures. And then the treatment, it says 2 to 6 weeks of IV antibiotics. And what I've seen is it's usually, in real life, a minimum of about 4 to weeks for the patient with their own native valve is infected, and then 6 weeks for the patient with a tissue valve. So that's kind of recommended by the guidelines also, where you have a longer period of time. And I've seen that question in review books, and I just couldn't believe it. It's so specific. But 6 weeks for the prosthetic valve, 2 to 4 weeks for your own native valve. And then after you clear the infection, if the valve is still affected, if it's still not working right, you still might need surgery to get it fixed. So this is diving a little bit deeper into infective endocarditis, but who needs prophylaxis with antibiotics to prevent it? Well, the top part of there is your main patients you need to worry about. Do you already have a prosthetic valve? Have you had endocarditis before? Do you have congenital heart problems? Or have you had a heart transplant? And they're getting some of these procedures down the bottom. I think those are the patients, keep in mind that they need your antibiotics. And the prophylactic antibiotics we're typically going to use are amoxicillin. So just use amoxicillin for those dental procedures. And if they're having some bowel or urinary procedures, ampicillin, gentamicin, both of them. Okay. So sometimes we can give them IV at the time of their procedure. Sometimes they take them PO for those dental procedures. And then I went a step further. If they're allergic to amoxicillin, use cephalexin. Okay. All right. Just a few slides on rheumatic heart disease, and then we're going to talk about atrial fibrillation. When it comes to rheumatic heart disease, this is related to a history of Streptococcus pyogenes or group A strep infection in the past. And typically, they had the throat infection, it didn't get treated appropriately, and now they've gone on to develop this inflammation and scarring of the heart valve. All right. It says it's the most commonly acquired heart disease in people under age 25. So it does affect a fair number of people. I found this one slide or picture that kind of encompasses acute rheumatic fever and what the patients may present with after they've had the pharyngitis, the tonsillitis that they get treated. So usually a younger person, kid or a teenager, you get tested, so the anti-streptolysin O is positive. The patient may develop arthritic symptoms, so that's not unheard of, but I love this picture because it talks about the erythema marginatum, the subacute nodules, and migratory polyarthritis. So all the things that can be affected in a patient with acute rheumatic fever. And then again, that goes and kind of scars up the valve, makes it not work right. And then just a couple of points out of this slide that I've really already made. You're going to do an echocardiogram to link the valve, no doubt about it. But mitral regurgitation is the most common valve disorder in rheumatic heart disease in young people. So young people aren't supposed to have mitral valve regurgitation. That is a generally old person type problem, or at least middle age and older. So when you see mitral valve regurgitation in a young person, you've got to think about this was probably rheumatic heart disease. But if you ever see mitral stenosis in a patient, you got to think this is probably rheumatic heart disease. Okay. So there is a difference in those two bullets up there at the top. So make sure you kind of learn that. And again, it's not just, it is a worldwide problem. So some folks, they'll get some primary prevention with things like penicillin. And then these penicillin injections are given monthly to prevent any recurrent infection. And then valve surgery as indicated. All right, don't key yourself too hard on rheumatic heart disease. You may never see that. Atrial fibrillation, it gets its own time outside of the EKG lecture. And so we're going to go through this rhythm and tell you all about it and all the medications that are used to treat it. So when it comes to atrial fibrillation, first of all, the normal electrical impulse travels from the sinus node to the AV node down the left and right bundles. But with AFib, it's chaos. There is chaos in both atrium. There's impulses coming from all over the place. These foci originating from all over the atria. And if you could count it, the atrial rate would be around 300 or more. But the AV node is smart. It says, no, I'm not going to let all of you impulses go down and pace my ventricles at 300 because that would be VTAC or VFib. So it stops a lot of those impulses. It limits them to about half of it. So 110, 140 is the usual ventricular rate and the heart rate of a patient who comes in with new atrial fibrillation. Excuse me. So paroxysmal AFib. There's just three types of AFib. First one's paroxysmal, kind of comes and goes, stops within 7 days. Persistent AFib, now it's lasting more than 7 days, and maybe it's taking drugs or a cardioversion to get them out of it. Permanent AFib, now we've done everything we can. We've tried cardioverting them, we've tried medications, all the antiarrhythmics, we cannot keep them in sinus rhythm. You can live with AFib, you can be in permanent atrial fibrillation and be okay as long as your heart rate is controlled with the medications that we'll talk about in just a few minutes. Please, please, please be able to recognize AFib for your board exam. If they don't put any other rhythm on there for you to recognize, I bet they're going to put atrial fibrillation. So make sure you have this one down pat. So there's no P waves. The QRS to QRS is irregular. Generally a little bit narrow complexes with atrial fibrillation. And then the treatment is based on what they look like. So are they stable? Are they just complaining of palpitations? Are they fatigued when they try to exercise? Do they get dizzy? That's a stable AFib patient. Versus unstable, now they're in heart failure. They're hypotensive when they get to you. Maybe they have angina. So you really are going to take on two different treatment routes when you treat these patients. Are they stable versus unstable? We're going to give you those in just a minute. Finish the history. You know, when does that happen? How many times a day does it happen? Are you staying in AFib? Do you know you're in it? Do you even feel it in the first place? Are you on a lot of caffeine that may have precipitated this episode of atrial fibrillation? Sleep apnea is terrible for your heart. So you need to treat patients aggressively with CPAP and weight loss if they have sleep apnea. And then all of these patients need a good cardiac workup. In other words, we're going to do an echocardiogram. They may eventually need a stress test. I've seen it work where your patient comes in an AFib and I find out they need bypass later on. I see a lot of patients who have bypass surgery and then they go into AFib. So it can work kind of both ways, but it's related to their coronary disease or structural heart problem. patients. When you're doing the workup, let's do an EKG, see if it looks like AFib. Let's do some baseline labs, make sure they're not anemic. Electrolytes, are they okay? I'm going to do some cardiac enzymes to rule out a myocardial infarction because they may release some troponins and give you a diagnosis of a non-STEMI because they have AFib and coronary disease. Are they hyperthyroid? That tends to be the reason patients go into AFib, is hyperthyroidism. Echocardiogram, I mentioned earlier, they may have atrial enlargement, so a big left atrium, and patients with big left atrium tend to get AFib. Do they have a tachycardia-mediated cardiomyopathy? So if you're in AFib for a month, and your heart rate's doing 130, your heart gets bigger and bigger and bigger and bigger, and it dilates, and now you're left with this ejection fraction that's significantly lower than it should be. Okay. So again, part of the workup is an ischemic workup. So doing a stress test, something to make sure they do or don't have coronary artery disease as a cause of their AFib. So maybe the patient comes in pretty stable, and we can give them medication. We just want to get their heart rate slowed down. So we give things like beta blockers, calcium channel blockers, digoxin. I've thrown in some mechanisms of action there that lets you have an idea of how they work. And I tend to use the calcium channel blockers just because I like the way they work, because they work at the AV node. In other words, they're helping the AV node do what it's trying to do in the first place, and that's to slow down some of those impulses as they're moving through the heart. And then there are patients that might require rhythm control. The way to get somebody back into a regular rhythm is to shock their heart back into rhythm. So direct current cardioversion, antiarrhythmic medications can be used. When it comes to cardioversion, sometimes we do those emergently, sometimes we do those electively. So the patients, they might come back in later on for us to do a cardioversion to get them back into a regular rhythm. But again, they're hypotensive. Let's get them back into a regular rhythm now. If we put them on an antiarrhythmic, here are some options. Amiodarone is an option. Let me point out a couple of things about amiodarone. First of all, it's a potassium channel blocker. And then you really need to make sure they have a normal thyroid and a normal liver before you start amiodarone, because it can be toxic to both of those things. So it can cause thyroid issues, it can cause liver issues. And then also, one a little bit more rarer thing is it can cause interstitial lung disease. So pulmonary toxicity. So it's not benign by any means. It comes with its issues. Sotalol is also a class 3 antiarrhythmic, has some beta blocker properties to it, but it also is an antiarrhythmic to hopefully get your patient back into a regular rhythm. Both of those first two medications can prolong your QT. All right, and a long QT can lead to torsades, right? That's no good. Flecainide and propafenone are a couple of sodium channel blockers. They are great for the patient who has a completely normal heart otherwise. So no valve problems, no coronary disease, structurally normal heart. Otherwise, you cannot use those medications because they become pro-arrhythmic, cause rhythm problems. Anytime you talk about AFib, you got to worry about a patient's risk for stroke. So when a patient comes in, we're going to ask them, how long do you think you've been in this? If they don't know, you can assume it's been more than 48 hours. And if a patient's been in AFib more than 48 hours, they have a risk of building up clots in their left atrium. And if one of those clots gets loose, it travels through the heart and out and can head up and cause that patient a stroke. We all have a left atrial appendage on the side of our heart over here. It looks like an ear over there. And that is where atrial clot really gets formed, and large pieces of thrombus can break off, go out of the heart and cause a stroke. So we calculate the CHA2DS2-VASc score, and I don't think you need to memorize these, but I'm going to show you on the next slide what you're supposed to do with a score of a patient that you've calculated their CHA2DS2-VASc score. But just to kind of look at them, do you have heart failure? Do you have high blood pressure? What's your age? Do you have diabetes? Have you had a stroke before? Way down at the bottom, everyone who's a female gets a point just because you're a female. It turns out females have more strokes related to AFib. And then I need you to look at this slide and your piece of paper and make sure that it coincides with what I have here, because things have changed in the past year, and I think it's time for it to be on your board exam. So if your patient has a CHAS-VAS score of 0, you don't do anything. If they have a CHAS-VAS score of 1 in men or 2 in women, you should consider anticoagulation. Aspirin is no longer in the conversation for atrial fibrillation. Okay, so it's not an option anymore. If their score is 2 or more in men or 3 or more in women, then you absolutely have to anticoagulate that patient. We do not want our patients having a stroke, so I lean towards anticoagulation on my patients with the appropriate CHAS-VAS score. All right. Now, what are your options? Well, good old warfarin's been around, generic, and it is a vitamin K antagonist. If I can antagonize vitamin K, then I can decrease those clotting factors and proteins, and that keeps my blood thin. All right. It's metabolized through the liver, so be careful. If patients have a bad liver, they may not tolerate your warfarin. The way we monitor a patient's warfarin level is checking their INR. It should be between 2.0 and 3.0. That is a therapeutic level for AFib. It's pretty much a therapeutic level for everything, for DVT, for pulmonary embolus, and now for AFib. Okay. Adverse drug reactions. Blood thinners will make you bleed, right? They'll make you hemorrhage and bruise. This one has some weird ones like purple toe syndrome, skin necrosis, which is not too common. But then this is important too. You cannot give warfarin to patients who are pregnant. It is teratogenic, so it'll hurt the baby. So do not give warfarin to patients who are pregnant. Be careful how much green leafy vegetables they eat. So it's not that they can't eat them at all, but they need to limit how much they eat. So they can't sit down and eat a whole pot of spinach or a whole pot of greens. That will counteract your warfarin, and you'll never get to that therapeutic INR. And then there's some medications that increase the warfarin effects, like fluconazole, imidazole, sulfamethoxazole, which is an antibiotic, and Bactrim, grapefruit juice and alcohol. So these things that are fairly common, these things increase your warfarin effects. So be careful with that. And then if you need to reverse a patient's warfarin level, we use vitamin K. We mentioned that earlier. That's what reverses it. There's a couple of forms of it there. It's usually given IV, but it can be given sub-Q or PIA. Also, what reverses warfarin is fresh frozen plasma. So if I have a patient who's hemorrhaging right now because their Coumadin level is really high, I'm going to give them FFP because it works faster. For a patient whose INR is just really high, but they're not bleeding, I probably will give them vitamin K. So it takes a while for that to work. And it lasts a while too. It lasts for several days. But just kind of knowing both of those things are available to reverse warfarin. But it turns out we don't use warfarin anymore for atrial fibrillation. This is now what's guideline directed, and this is what's guideline recommended because they're safer. They don't require any lab monitoring. You don't have to restrict what they eat. And so these medications work just great, and these are the ones we choose for patients with atrial fibrillation. Okay, so you'll mostly see this on patients. Now, the one pearl I think I would get you to remember is the dosage adjustments are required in renal insufficiency. So if your patient has chronic kidney disease, their creatinine clearance is not good, you got to back off on the dosages of these medications. Not to say that they're contraindicated, but you at least have to back off on the dosages based on their renal function. All right. And they're just safer. They're just safer. So it says DOAC's preferred over warfarin if no mitral stenosis. So the commercials will say, if you have atrial fibrillation not caused by a heart valve problem, well, that's what they're talking about, mitral stenosis. Then you can take these medications. Summary slides, if they're hemodynamically unstable, just pop them, cardiovert them back into a regular rhythm to get them stable again. Most patients are going to be hemodynamically stable. So I think for your board purposes, just shoot straight across, rate control and anticoagulate. Look down here at the bottom. This is where we might do a TEE to see if your patient has atrial clot. And if they don't, then you can do the cardioversion. Because concerning is if I get my patient back into a regular rhythm, now their atrium is contracting to push the clot out. And so that's really, I'm almost rather them stay in AFib and let's get them anticoagulated for about 3 weeks and then bring them back and do a cardioversion. So there's multiple ways to treat AFib. The cure for atrial fibrillation is an ablation. So a lot of patients get an ablation, and this is like readily available. All the electrophysiologists, cardiologists, they are busy doing AFib ablations all the time. And hopefully it works after the first one. Sometimes it takes the second one. But we know AFib comes from around those pulmonary veins. So they go up there and put a catheter and burn around those pulmonary veins to hopefully eliminate the atrial fibrillation. All right, just a couple of minutes left. Let's look at these questions. 23-year-old male presents to the emergency room with sharp chest pain radiating to his left neck and fatigue. Last week, he experienced severe nausea and vomiting attributed to gastroenteritis, and that's now resolved. Physical exam, there was a loud abnormal scratching sound and insystole and all of that, located near the cardiac apex. Chest X-ray normal, blood pressure is 120/80, heart rate 88, he's afebrile. What's your initial plan of care? So this patient had a recent viral syndrome. I think this sounds like pericarditis. Got a scratching sound, and I'm going to treat him like that. So 14 days of indomethacin, follow up in 2 weeks. Remember now we've added colchicine, so that's another part of the treatment. But all these other things, he doesn't need IV steroids. He doesn't need blood cultures. He's not febrile right now. I don't think this is a pulmonary embolus to do a CT chest on him. So this is a young guy with pericarditis. 82-year-old male with a history of persistent AFib and hypertension presents with increasing dyspnea exertion. Chest X-ray shows a honeycombing pattern and pulmonary function testing show a severe restrictive defect. Which of the following is likely causing the symptoms? So since we just talked about it, it's probably amiodarone, right? But why? Amiodarone causes pulmonary toxicity in the form of interstitial lung disease. And interstitial lung disease and pulmonary fibrosis show up on a chest X-ray as a honeycombing pattern. Your PFTs will show a restrictive defect. So these are things that we see with amiodarone use. Unpredictable. You may not know. You can't necessarily predict who's going to have it, but you're supposed to do some routine PFTs and X-rays to keep track of your patient. Because it doesn't get better. You can stop the amiodarone. It won't get worse after you stop it, but it won't get better. So it's just the damage is done. 67-year-old female with a history of breast cancer and tobacco use complains of dizziness and dyspnea exertion. Her heart sounds are distant. Her systolic blood pressure is noted to markedly decrease with inspiration. Which of the following is a likely diagnosis? So it gotta be cardiac tamponade. What's it called when your blood pressure decreases with inspiration? Pulsus paradoxus. 22-year-old college student with no prior past medical history presents to the ER with complaints of palpitations and dizziness that started 8 hours ago. States he was drinking heavily at a party last night. He denies chest pain or syncope. His blood pressure is 80/50. Heart rate's 160. Respiratory rate's 24. O2 stats 94. Here's his ECG below. What's your initial treatment? So first of all, you have to decide what the rhythm is. And the answer to that is atrial fibrillation, right? And I'd say he's fairly symptomatic. And so that limits your treatment plan to, I need to get him back into a regular rhythm because he is hemodynamically not tolerating his atrial fibrillation. So the answer is, sure, give him some IV fluids because that's easy. And then he needs a cardioversion to get him back into a regular rhythm. I wouldn't send him home for 3 weeks. He's too unstable. I would not give IV diltiazem because that's going to make his blood pressure worse. I don't need an echo to look for atrial thrombus. One, because it doesn't do it very well. And then two, he's not been an AFib. He's only been about 8 hours, so, or less. So it's unlikely that he has clot. All right, guys, it brings to the end of cardiology section 2. And I see just 2 or 3 questions. So let me